так, колеги, з вами і скажу, що коли ми почали анонсувати цей захід, то був деякий скепсис і казали, що от, можливо, така вузька тема, вона не популярна для України. Але, друзі, саме через те, що велика кількість питань, які сьогодні будуть розглядатися, дійсно, на нашу думку, недостатньо велика увага їм приділяється, і ми б хотіли їх, що називається, підняти трошки на поверхню. Ми розуміємо, що йти протореним, відкритим, протоптаним шляхом легше, але відкривати нові стежки завжди цікавіше. І хоч це несе певні ризики, але це того варто. І, друзі, зважаючи на це, я хочу подякувати абсолютно всім вам, тому що ви з нами в цей суботній вихідний день, тому що дуже дякую безмежно вам за те, що ви поділяєте нашу зацікавленість і наш ентузіазм, друзі. І я з великим задоволенням для вітального слова, колеги, хочу передати свій мікрофон доктору медичних наук, професору, головному спеціалісту з акушерства і гінекології МОЗ України, завідувачу кафедри акушерства, гінекології і репродуктології Національної післядипломної освіти медичної і виконавчому директору Асоціації акушерів і гінекологів України Камінському В'ячеславу Володимировичу. Вітайте, будь ласка, колеги.
Шановні колеги, щиро радий передати вам офіційне вітання від керівництва Міністерства охорони здоров'я, від президента Асоціації акушерів і гінекологів академіка Запорожного Валерія Миколаївича. Я дуже радий бачити перших осіб в нашій спеціальності культурних гостях в Україні, в Києві. І думаю, якраз такі мероприємства і участь фахівців такого високого рівня дозволить говорити нам про те, що ми чітко інтегруємося в міжнародну роботу, ми чітко інтегруємося в роботу Європейської нашої асоціації. І я думаю, що не потрібно нам тут сотні учасників, якраз ті люди, які щиро зацікавлені, якраз будуть сьогодні слухати доповіді, будуть приймати участь в обговоренні, в дискусії. Якраз це ті люди, які будуть рушійною силою і запорукою успіху в тому, чим ми з вами займаємося. Ми пам'ятаємо про серйозні демографічні проблеми в Україні, ми пам'ятаємо про різке зниження кількості пологів на 20%. За 3 роки стало менше народжуватися дітей. А кількість сімей, яка на превеликий жаль не має дітей, вона аж ніяким чином не стала менше. Тому актуальність, без сумніву, дуже велика і необхідність і потрібність цієї роботи однозначно є. І я дуже ще раз дякую нашим фахівцям, які приїхали для того, щоб поділитися власним досвідом. Дякую і починаємо працювати.
Дякую, В'ячеславу Володимировичу. Друзі, ще для наступного слова я з великим задоволенням хочу передати мікрофон головному редактору журналу «Жіночий лікар». Це Світлана Іванівна Жук, професор, доктор медичних наук, завідувач кафедри акушерства, гінекології, медицини плода і заслужений лікар України.
Дякую. Шановні колеги, мені дуже приємно стояти сьогодні перед вами в якості головного редактора журналу «Нашого жіночий лікар». Я погодилася на цю посаду, яка, хочу сказати вам, дуже непроста. Ми маємо велику відповідальність перед вами. Тільки тому, що це журнал для практичних лікарів. Журнал, який найбільше читають і який, сподіваюся, люблять лікарі. І ті теми, які ми будемо піднімати, я думаю, вони вам цікаві, тому що ми зробили невеликий опрос, і дана тема була вами підтримана. І прошу подавати свої заявки і далі на сайт журналу нашого з побажаннями, що б ви хотіли послухати, і яких фахівців світового рівня ви хотіли б побачити. Ми працюємо для вас, ми відкриті для вас. Дякую вам за співпрацю.
Дякую дуже, Світлана Іванівна. Шановні колеги, гарну справу завжди добре робити, коли в тебе є однодумці і люди, з якими тобі комфортно, які тобі допомагають. І я не можу не висловити слова подяки нашим спонсорам. Це всесвітньо відома компанія європейська Гедеон Ріхтер. Вона має більш ніж 100-річну вже такі гарні традиції. Це соціально орієнтована компанія, яка завжди підтримує ось такі освітні заклади. І 2 клініки – це приватні медичні заклади, клініка репродуктивної медицини «Надія» та пологовий будинок «Лелека». І зараз я хочу для вітального слова передати з великим задоволенням мікрофон науковому директору клініки репродуктивної медицини «Надія», професору, доктору медичних наук Судомі Ірині Олександрівні.
Вельми шановні колеги, шановні гості, я вітаю вас з початком наших студій, присвячених такій непростій темі, як мікроінвазивні втручання, малоінвазивні втручання, ендоскопічна хірургія в епоху ДРТ. І вважаю, що це дуже актуальна і дуже правильна тема, тому що ви знаєте всі, що цими речами, лапароскопіями, ендоскопіями займаються, як правило, одні лікарі, ДРТ інші. Іноді буває і що одні і ті самі, одна і та сама людина цим займається. Але дуже важливо знати, що конкретно показано цьому пацієнту. І особливо це важливо для лікарів, репродуктологів такої первинної амбулаторної ланки, щоб вони розуміли, що, коли і як краще зробити для отримання гарного результату у пацієнтів з набліттям. Тому я бажаю нам успіхів, щоб наша симфонія, пані Лариса написала, наша опера, можна сказати, пройшла за аншлагом, з успіхом. І бажаю вам гарного уікенду, щоб наша конференція вам тільки покращила.
Дякую, Ірина Олександрівна. І нарешті, друзі, я хочу передати, взагалі хочу сказати, що наш захід і цей проєкт не зміг би відбутися, якби ми не працювали дуже тісно, у тісній такій співпраці із Міжнародним відділом Асоціації акушерів-гінекологів України. Його очолює доцент кафедри акушерства і гінекології №1 Національної медичної академії післядипломної освіти Андрій Володимирович Ткаченко. От він вже приходить, і я хочу сказати, що Андрій Володимирович, крім усього, що я перечислила, ще й представляє Україну в Європейській асоціації акушерів-гінекологів України. І перш ніж, друзі, я передам Андрію Володимировичу мікрофон, бо я вже сяду, то я хочу сказати, що будьте, будь ласка, активним, бо традиційно задавайте питання спікерів, включайтеся в дискусію, тому що ми попросимо спікерів вибрати лише двох найактивніших учасників, а для вас у нас є дуже гарні подарунки. Все, з великим задоволенням передаю мікрофон.
Дякую, пані Лариса. Дякую всім, що зібрались, незважаючи на вихідний день, фінал Євробачення, багато цікавих подій в Києві. Мені дуже легко, бо всі наші попередні виступаючі сказали, власне, все, що я мав сказати. Єдине, що мені залишилось, дуже почесна роль представити, звісно, наших гостей. Можливо, з цього треба було починати, але всьому свій час. Тобто зараз у нас в Києві дійсно вперше представники Міжнародної асоціації репродуктивної хірургії і маткових труб. Серед наших гостей Стефан Горц, минулий президент цього товариства, директор і засновник Інституту вивчення репродукції з міста Льовен, Бельгія. Серед наших гостей доктор Камал Оджга, він обраний президент цього товариства, працює старшим консультантом університетського шпиталю Сен-Джордж в Лондоні. Серед наших гостей шановний професор Антуан Латрелот з Льона, Франція, також попередній президент цього товариства, а також попередній президент Середземноморського товариства репродуктивної медицини. Єдина чарівна жінка в команді наших прославлених і чудових експертів, професор Марта Дірнфілд, яка приїхала з міста Хайфа, Ізраїль. Асоційований професор доктор Джей Пракасан, прибулений з Сполученого Королівства. І хід сезону найбільш досвідчений, найбільш артистичний, найбільш емоційний, найбільш заможний, мабуть, я не знаю, але він всім роздає свої візитні карточки. Професор Дідіс Грузинськас. Say a few words. Ще раз поаплодуйте. І можливо, just a few words to participants. Kamala, but... Oh, yeah. Forgive me. Зараз я вже буду кланятися, вибачте. Безумовно. Ну, бачите, не буває іронії без іронії. Ми ж зібралися акушери, гінекологи, репродуктологи, такі собі хірурги, фахівці досвідчені в цьому. І ми зазвичай забули людину, головну в цьому процесі. Професора Еріка Ернста з Данії, з університету Голкута. Він спеціаліст з ембріології. І всі наші намагання щось зробити без нього не будуть працювати. Але так часто буває, що акушери-гінекологи можуть забути в лаврах своєї слави про своїх колег, без яких не можна працювати. Вибачте.
On behalf of the International Society for Reproductive Surgery, I would like to thank the organizers of the Ukrainian Obs and Gynae Society for welcoming us and giving us an opportunity to share our knowledge and experience today. We would like to say that we are overwhelmed by the way we have been looked after since arriving from the airport till now. And we're looking to this exciting opportunity to interact with you. We want to share our knowledge and also share your knowledge with us before we go back. I hope we'll have a great day and we'll be interacting with each other. Thank you.
Так, ну і так як у наших гостей презентації насправді дуже цікаві, і у нас такий щільний графік, що його б вистачило на 2 дня конференції, але всі вони працюють, всі вони переважно пов'язані не тільки з університетськими шпиталями, але й з приватною практикою. Вони або власники, або керуючі директора приватних клінік, тому вони змогли приїхати лише на один день. Я дуже прошу дуже активно, але в межах графіку працювати. І я б хотів запросити до ведення першої секції і передати мікрофон шановній Світлані Івановні, Жук професору, і нашому колезі доктор Прокасану.
Дякую. Починаємо нашу роботу. Колеги, я з великим задоволенням до слова запрошую першого виступаючого. Це професора Гедіс Грудзінаскас, почетного професора акушерства і гінекології школи медицини при лікарні. Ну, дуже багато треба прочитати, але я думаю, перед вами є програмка. Просто скажу, що професор з Лондона, його дуже гарно представив Андрій. І тема повідомлення значення маткових труб для забезпечення жіночої репродуктивної функції від фізіології до найбільш поширених патологічних станів. Прошу, професор Гедіс.
Thank you. Thank you. Thank you very much. I feel very honored to be back in Kiev again. You may not know, 10 years ago I had a haircut in Kiev, and both ears are still here. 10 years ago I had many, many happy times in Kiev. I have had the caviar, I have been mugged, I have had a lot of intellectual and historic and cultural stimulation. And I was so pleased to receive the invitation and enjoy the company and become acquainted with new colleagues, Professor Kaminsky, Professor Larissa, and Professor Andrei, and Professor, where is she gone? Oh, here you are, Professor Svetlana. I almost missed you. And so it doesn't matter what is written in the program. This is me, according to the daughter, 5-year-old daughter of one of my patients who I'd never seen. And she drew this 3 days ago. So you can see where I work. And the detail is absolutely correct. You will see the flowers, you will see the computer, but there are some things that are wrong. Now you will see, Evgeny or Anna, are you ready? I do not have big hands like this. She gave me big hands. I have little hands like Donald Trumpsky. And so there are some things that are not correct, but detail is correct. The other, can you see anything else that is not correct? The tie. The tie I wear is circumcised. This one is not. So, moving on, but I come from a long line of heroic non-surgeons. You can see this. The scalpel is in the left hand of my distant relative, the Grand Duke Gediminas from Vilna. That's what you call it. It's actually called Vilnius. And who are you? Well, my goodness me, I have had such joy and stimulation from one of your colleagues who, like some of you, have 2 careers, not just medicine. Professor Ernst, he is a pig farmer, and he does many other things as well. And I have been so stimulated to read of the wonderful work and the stories of Mikhail Bulgakov. And it came to my notice that he, in fact, has inspired so much work in our area in his book, The Transplantation of Ovarian Tissue. When I am reincarnated, I will become a dog. Dogs have more fun. I have to declare a conflict of interests. It's important. We heard about money and private clinics and how much we have to give, and we give potatoes. You give potatoes, you get 2 minutes. You have cake, you get 4 minutes. If your grandmother bakes the cake, you get 6. So I declare my interest. I like the fallopian tube, and that is why we're here. Is there anybody here? Yes, you are. There are some people here who are under the age of 40. But there are one of you maybe, and no, you're not. We have a 0.2% chance of one of you not being in the fallopian tube. So you have all been in the fallopian tube. But I declare the fact that I like it. And I will say to you that at that time when I was in the fallopian tube, in Kaunas, it was popular. It was popular in my father's family because I have 2 siblings. It was safe. I am here. It was nurturing. Well, I'm not as tall as Professor Andrei. It was warm, and at that time, may I say, bacteriologically and virologically clean, because all the others died from other diseases. But in 2017, and that's the other reason we are here, the popularity of the fallopian tube is decreasing. In Belgium, 25% of children are born, 4%, 1 in 25 is born outside the fallopian tube. It's also less safe because of the way we behave. Not in Ukraine, you are a polite society, but in other parts of the world. It's warm, it's not always so clean. Tatiana, where are you? Is any of this important? I was discussing this with Professor Valeri. He is busy working. Valeri, Zukin, Professor Zukin, are you here? He's busy working. So good, keep working, Valeri. But we discussed these little things here. And he kept saying to me, so what? So I asked colleagues here, Tatiana, Anna, where are you? Evgeny. Is it important, the fallopian tube?
Yes, very important.
Correct answer, very good. Da, not yeah, da. Evgeny, gentleman's opinion, where are you?
Yes.
Stand up, come on, stand up. You have to throw the voice out. Da. It's important. And Professor Kaminsky has already given my lecture. Where are you, Professor Kaminsky? You looked at the slides. Andrei didn't look at the slides before I showed this. Why? Look at the birth rate. Zero population growth, none. Why? Well, all this makes this meeting and the collaboration so important. Coming now to the biology, this is the sociology, coming now to biology. Evgeny, did I tell you the answer to this or not? What do guests, fish and embryos have in common? Anna? Where are you? Where's Anna? Tatiana, where are you? Or is it another name? Lady in green, what's your name? Tatiana. Speak to me, Tatiana. What do these embryos, fish and a guest have in common? We have to go to not pre-Trump America. Benjamin Franklin, the polymath. He is like Eric Ernst. He is masterful in many things. Eric, it's a compliment. Okay. I will let you know when it's an insult. So, guests like fish, they shouldn't stay too long. And this is exactly the biology of the tube. Exactly. Right? Isn't God clever? Or was Benjamin Franklin clever? One of you is clever. Yeah? And this, when we are there just for a few days, it's safe. And that's why we're here. Well, that was the embryos. Right? And we talked about the guests, the fish we'll eat later, right? So what is the alternative to the fallopian tube? This you know, because I've shown this slide before, is the first incubator for human embryos. Sorry, the first one that people believe is the first in Cambridge, of the step down Edwards. Does it look safe? Looks clean. And we have done better than this. Look at this. In it goes, 5 days later, out it comes. You can watch it on the screen, the embryoscope. Right? Another type of incubator, the alternative to the fallopian tube. Well, we know that it's less popular, but what is better? Our fallopian tube, the one we wish to preserve, to protect, the one that is better, right? There are some advantages. Low cost, low maintenance cost, multiple use, not disposable. I mean, I have two siblings. They walk down the fallopian tube. I don't know whether it was the left or the right one. So, again, the relevance of the fallopian tube. So life is short, it's sweet, it's safe. And it's better. I believe it's better than in the ART incubator. Evgeny, is that right?
Yes.
Da, good. Anna? Yeah, good. So the majority. Tatiana? Yeah? Da, good. Okay. So it is better. But why? What is the benefit? Okay, we can do IVF, ICSI, PIXI, MIXI, ART, but from natural conception, on the balance of probabilities, less premature birth, less consequences of that, better birth weight, and there are other benefits which we know about, but I've just about run out of time. The last 3 slides concern the common pathologies because the rest of the day is devoted to them. So I will have a few words about ectopic pregnancy, and I have 1 slide about carcinoma because Professor Watrello might want to use it, and I'd forgotten about this work, and he probably knows it already. So ectopic pregnancy, you know, is very important. I've highlighted the important part in red. So after IVF, a high incidence. We are aware of that. Ectopic pregnancy in couples with tubal infertility is common. We know that. So we should look after our societies. Ectopic pregnancy can occur everywhere. But in the right tube, mainly. Why? It's not the appendix. That's not the villain. Is it the temperature? Is it what we had for breakfast? I don't know. These are strange things, and this is why the society forms to learn. And my final slide concerns cancer. Right? What is the incidence? Because this is the subject of this afternoon's lecture. What is the incidence of tubal fallopian tube cancer, primary cancer? And in our study of over 20 years ago, when we looked at over 20,000 women screening for ovarian cancer, right, we stumbled upon this and wrote it up, and it was forgotten until this society has brought it forward, right, once again. Ladies and gentlemen, thank you very much.
Дякую вам також. Питання зразу задаємо. Лариса, не бачу Ларису. А може по свіжим слідам, там 3-4 питання, так? Прошу, колеги, хто бажає задати професору питання? Ви подумаєте, так? А потім Евгений Иванович. Ну, он подумает и обязательно еще вам задаст вопрос. А маєте питання? Прошу. Микрофон.
Thank you for your best presentation. I have a question. What do you think about the role of deep longitudinal folds of funnel?
The role of
Deep longitudinal folds of funnel of fallopian tube. The role
of the deep longitudinal.
your opinion.
So, thank you very much. This is a very important question. Because the correct answers will be given by those who have been in the tube many times endoscopically. What is important is for us to understand how important the microanatomy, not the histological, microscopic, the microanatomy is in the fallopian tube. And it's only since falloposcopy or salpingoscopy, looking inside, that we are able to understand this better. So I believe it's very important. I believe we need more information, not just the appearance. And if they are interfered with, either by inflammation or infection, primary or secondary, then we have these common pathologies. Thank you for the question.
Дякую. Ще прошу питання. Будь ласка.
Professor, thank you for this presentation. And I have only one question: why in the right tube, yes, the ectopic pregnancy is more often? Thank you.
Thank you. I didn't ask you to ask this question, but I'm so happy you did. And I don't believe it's to do with ovulation, which is on the extra slide, which I'm not showing you. Okay? Right? So there are lateralized events. We expect when we have two organs, left tube, right tube, that events occur at random. But in fact, they do not. And so we are discussing the disease here, the diseases. The other disease which is lateralized, we will hear from Professor Kaminsky later, endometriosis. This is also lateralized. What's going on in there? Well, I'm not allowed in there very often, but we need to study these things. I don't think it's to do with ovulation, because that is also a lateralized phenomenon, as we see here. There's just a dextro, right side, a preponderance for ovulation. So it should be the microenvironment. The simple things, is it temperature? I don't know. But it fascinates me. But it's not to do with the occurrence of appendicitis or its surgery. We looked at this in a publication that's buried somewhere. Yeah?
Thank you.
Дякуємо, доктор Гредіс. Немає, так, питань більше? Тому продовжуємо нашу роботу, і я з великим задоволенням до слова запрошую доктора Камаля Ойга, також з Великої Британії. І надзвичайно приємно, що доктор Камаль організував товариство міжнародне з вивчення маткових труб. Уявляєте? Товариство. І я думаю, що він має великий досвід з даного питання і з задоволенням послухаємо його повідомлення, яке стосується нехірургічних методів оцінки стану маткових труб. Прошу, доктор Камаль. Все. Вийшло.
Thank you. So, what we're going to discuss today will be looking at non-surgical methods of assessment of the fallopian tube. If you look at the options we have transvaginal scanning, history of pelvic inflammation, chlamydia antibody testing, HSG, the X-ray, the common method. We have hycosi, laparoscopy, and fetuloscopy. And of these lists, if you look at them, the two commonly used methods are HSG, the X-ray. It's one of the commonest methods in the UK, in the United Kingdom, and hycosi, the one that I like a lot. So there'll be a little bias in this lecture, that I'll be talking more on the hycosi than on the HSG. So, if you look at the gold standard, it's laparoscopy, fetuloscopy, but it's got some risk. It's costly. You need theater, you need equipment, you need to use a method which could be a screening method to select the patients that need laparoscopy or fetuloscopy. And that is what is the focus of my lecture. So, what is the screening method should have? It should be sensitive, specific, safe, widely available, inexpensive, and it goes on. But it should be able to identify which ones. I'll refer to Antoine, who will do a fetuloscopy, or Stéphane, who will do a laparoscopy. That's what we need as a simple method in the clinic. And if you look at the simplest method, which I think we should all use, is just do a transvaginal scan and do a chlamydia test. And if your transvaginal scan doesn't pick up abnormal, the tubes, cannot see the tubes, and the chlamydia test is negative, then you're done. Probably the tubes are fine. You can go ahead with treatment. So look for hydrosalpinges, see the uterus and the ovaries are normal, see that when you're touching the uterus, you're touching the ovary, they're non-tender, they're mobile. And if you do a chlamydia test, and if it's negative, or the chlamydia antibody test is negative, then most likely your tubes are fine. And I tell my patients, it's up to you. Do you want to test the tubes by putting a dye in, which will cost you and will be painful, or you just want to try? Because to me, the only test for the tubal patency, the best test is pregnancy. If you're pregnant, the tube was fine. Because all the tests we have are patency tests. They're not function tests. Of course, Antoine will tell you how the fetuloscopy, or Stéphane will tell you how fetuloscopy has moved closer towards finding the function test. That's the next lecture. I want to encroach into that. So, let's go into the technique I get obsessed about hypoxia in the HSG and how you should be all doing it. I'll invite you to come and see me doing a hypoxia, and you'll see it's so simple. Hopefully today you'll be convinced that this is the way forward if you're not practicing it in your practice. So you need to insert a catheter. You need to put the catheter in the lower part of the cervix and then inject a dye. So where the HSG is concerned, it is generally done around 7 to 10 days of the cycle. I won't go into details about here because most of you all know this information. And if you look at the HSG, it identifies the cavity very nicely. You don't need an expert to say that because the technician is doing the X-ray, and can be therapeutic sometimes because the dye may just open up the tube. The oil-based dyes are more likely to be more successful. And it can be performed in low resource setting. So the sensitivity, 65% sensitivity. There have been several studies showing this. But pelvic pain and discomfort and the problem with the oil-soluble contrast dyes have made us move towards water-soluble dyes. So we mostly use water-soluble dyes for HSG. Although I'm sure my colleague Geddes will be saying that we should be using the oil one because then the chance of pregnancy goes up. And I'll show you a paper a little later which shows that. So let's see, these are two pictures which you've all seen, probably see the cavity seen nicely, the tube seen nicely, and here you see the dye is not going beyond the corridor. It could be possible that she's having a spasm and that's why the dye is not going through, or it is blocked. Let's go to the hypoxia, which is hysterocontrast sonography. And the way I would like to do it is, my first assessment is doing the baseline scan, checking the uterus and ovaries, then examining her, putting the tube in the cervix, and examining the cavity and the tubes. I use 3D because I have the machine. You don't really need to use 3D for checking the tubes. 3D is just for showing off how good you are. But 2D is the basis of the whole process. So you can use air, you can use saline, you can mix air and saline and do it. You can use albumin, micro air bubbles. The one that I use is hydroxyethyl cellulose, called XM. And these have micro bubbles, and this is what reflects on this. I'll show you some videos in the end. Let's look at how we prepare for the patient. So it's day 5 to day 13. I send them an information leaflet about the process, so they understand what to expect. They receive some painkillers, some antibiotics after the procedure. And the position is more like a lithotomy position. And you must remember that these processes can hurt your back because you'll be bending down and seeing, so you make sure you're comfortable because you'll be doing a lot of these procedures if you are one who does hypoxia and scans. The catheter should be put to the cervix rather than the cavity. Sometimes it slips out, then I put it in the cavity. But otherwise I keep it in the cervix so you can see the whole cavity. I use a thinner catheter, 5.5 French. And I use a bit of fluid around the catheter that helps to retain it, so the dye can be forcefully pushed forwards. And of course, this is the most important thing. Watch the patient. Because if you don't, she won't allow you to do anything. She's stressed. She's been reading everything on the internet. She read all the horror stories. So if you watch what is happening to her, relax her, give her the confidence, explain to her, you'll find the process is very simple. It's very easy. So when I do the baseline scan, I explain to her what I'm seeing. Her focus is now on her uterus, her ovary, her reserve, any polyps, any fibroids. So now she is with me. She is my team. So when I do the hypoxia, she's cooperating with me. So get her on your side. These are very important things to me. And I'm sure, hopefully, these are the few messages you'll take if you start doing hypoxia. So there were many dyes that came. There were Ecovis and Sonoview. I use the XM, the hydroxyethyl cellulose. It really, the dye is just a way of seeing the flow into the tubes and the cavity. We also have used Doppler in the past. So how do you diagnose tubal patency? What are the key things that have been published and proven? If you see the flow of the dye in the proximal part of the tube for 5 to 10 seconds, that means this tube is patent. Because if it's keeping on flowing, it's flowing out. The end of the tube may be difficult to see because bowel of the tube. But if you can see that the dye is coming out in the end, again, that's your second point to prove that the tube is finished. Of course, you can use Dopplers. What do you need now? You should be good in scanning, transvaginal scanning. You should place the catheter in the cervix. Sometimes it slips out because there are multiples. The cervix os is slightly open. Then you need to put it further into the cavity. There's a learning curve. Anything you do, you need some more experience. So I generally say, if I can take you through 10 to 30 hyposes, you'll be able to do it. Eric, who's sitting here, he saw me doing 2 cases. He went home and he started doing it. He said, Kamal, I've started. So some people learn faster than others. But generally I've seen with my trainings, they take about 10 to 30 cases. So here you can see, randomized trials have shown that if you put the dye, you flush, there's a pregnancy rate can go up. In the oil soluble, you can see it's almost 24 to 38% compared to the controls of 8 to 21%. So if you tell that to the patient, she's going to cooperate because she says, oh my God, this test can make me pregnant. So they cooperate with you. And I tell them 5%, I give them a lower rate. Because in my practice, when I've done 20 cases, one of them gets pregnant. That may be coincidence because I'm not doing a randomized trial, but then there are patients who get pregnant. Here you can see the catheter. It has been put beyond the internal os because in the multiple patients, sometimes the catheter slips out. And you can see the key thing here I'm trying to say for those who are learning to scan or who are trying to improve the scan is, look at where the probe is. It is in good contact with the uterus. So the sound waves now are going beyond the uterus. My image quality is good because I have good contact with the uterus. I'm almost hugging the uterus with my probe. I'm touching it. And that's what I want you to learn, not the theory bits today. How you can scan and get a good image from a cheap machine. Of course, if you have a good machine, you can afford it, then you have good images. But you may still have a bad image if you don't have a good contact. So, there are many advantages. It's over laparoscopy, there's outpatient. The partner or the husband are sitting together and they're seeing the hypoxia. There's no visceral or vascular injuries, and she's not fasting. And she gets the results straight away. And she makes a decision about the next step. Of course, with HSG, there's no iodine. And the radiology department is not needed. You or anybody else who does it can do the test. There are additional advantages. When you're doing the scan, so I look at the uterus and I say, look at normal morphology, you've got no polyps, you've got no fibroid. I count the follicles, called antral follicle count. If you've got 1 or 2 follicles in an ovary, you are perimenopausal. If it's 3 to 5, you're in low reserve. The 6 to 11 is average. Above 11 is above average. So I can tell them the result in the same settings while doing the tubes. If you see the hydrosalpinges, then I don't do a hygiene. I tell them your tubes are affected. And of course, it prevents the laparoscopy itself. The evidence, there are a lot of publications that have shown now hypoxia is standard. The NICE guidelines, which are the UK standards, have said that you should be doing hypoxia as the first line of investigation for the tubes. There are limitations, and under limitations you must say that it's got a false positive result of 5 to 10%. It is unable, sometimes you're unable to see the whole tube. Visualization could be a problem. There could be times when you can't put the catheter and there's spasm, and she doesn't allow you to do it for whatever reason. So 3D. When I started scanning, I did 1D, which is like an image, like a picture. And then these pictures were put into a slide. 24 images became ambiguous, called 2D. Then came 3D, which is like 1D, static. 4D, which is moving. 5D is coming soon. I don't know what it is. But, so if you look at the Dopplers, or the evidence there's a lot of evidence from the Chinese group who've shown that the 3D hypoxia is better. To me, I think your 2D is far superior than your 3D. But the 3D gives you additional information for the lectures coming up. You try malformations. Doppler may help you. If you can't see the dye going through, just inject the Doppler, put the Doppler on and inject the dye. You'll see a flow coming through. But I don't use Doppler a lot. Let me come to some of the images that I've got. So this is I'm talking about 2D examination before doing the high dose. So if you do this, you see a nice triple layer, but if you do not move your probe and see the whole of the uterus, you're going to miss something. This is one of my teaching slides. So my registrar moved the probe a little bit, and what did he see? He saw a small polyp on the side, because if you just scan the middle, leave it there, you're going to miss something. So small polyp can be picked up. Nowadays we do 3D. So what does 3D do? It gives you a little hill around the endometrium called the junctional zone. If the junctional zone is interrupted, it may affect implantation, which Martha will speak about later, so I will not interrupt her. You may pick up endometriosis, so dermoid cyst. You may pick up, the woman has got polycystic ovaries. You may pick up, in the past we used to call arcuate uterus, but this is the subseptate uterus in the modern classification. If you're scanning with 3D, this is a follicular phase, so the endometrium is a little lighter. If you want to scan for abnormalities in 3D, then you should do it in the luteal phase, which gives you like an echo, because it's got progesterone, it's got mucus, which is thicker, which reflects. And sometimes you pick up this, unicornate uterus. And with the dye, you can see the cavity so beautifully. If you've got a malformation, make sure your catheter is below the septum, so you can see the dye going in both sides. So here are some videos, if it works. Sorry. I'll play the videos in a while separately because it's not coming up here. So, in short, hycosi and hysterosalpingogram are good screening tests. They only check patency. It doesn't mean the tube is still functioning. And that's something you must emphasize with the patient. Hycosi is simple, is low cost, and we can diagnose abnormalities of the pelvis. I think fertiloscopy, which is the next lecture, is the best test available for patency and tubal function. As I said before, and I repeat, intrauterine pregnancy, spontaneous conception suggests a normal functioning tube. Thank you. I'm happy to take questions.
Дякую, доктора Камаль. Прошу питання задавати, колеги. Немає питань, так? Thank you very much. Sorry.
Thank you. Sorry, this is very quick. I have been asked to make a statement. Professor Andre asked me just for accuracy. The data concerning pain from hysterosalpingogram is historic, and when you have the hysterosalpingogram done by Professor Andre and like-minded colleagues who have exactly the same approach to the teamwork with the patients come back and want to have another one done. It's such a gentle, effective procedure. The last point, so that's a statement from Professor Andre. I will make another last point. It's not a question. And the last point is the data concerning granuloma formation, consequent to the use of lipiodol, is non-data. Thank you.
It looks like you guys have understood a lot, so no questions.
It was a fair question.
То був великий коментар. Дякуємо вам, професор. Thank you very much. Продовжуємо нашу роботу. Я з великим задоволенням запрошую до слова професора Стефана Говардс, який приїхав до нас з Бельгії. Він є екс-президентом Міжнародного товариства репродуктивної хірургії, керівником працівником і науковим директором Інституту фертильності і ембріології. І тема його повідомлення – діагностичні та хірургічні можливості трансвагінальної лапароскопії. Прошу, професор Стефан.
So first of all, thank you very much to Andrew for inviting me over here, and also for all the collaborators. It's really a great pleasure to be in Kiev. It's my first time I'm here, and already yesterday evening we had a tour around Kiev to understand a little bit more of the history of Kiev, which I have to confess I didn't know nothing about it, or we didn't follow it very closely. So I'm very pleased that we are introduced here in Ukraine and start to learn a little bit more about your country. So I'm also thanked to Kamal, who said that in fact the transvaginal laparoscopy will be a very good thing to evaluate the tube. And so, but I also agree with him that in fact the ultrasound has to be used as a first screening method. Now, what's happening in the last years, at least in Europe, what we are seeing is that it has been questioned if we still need an investigation. And what happens at this very moment is that patients are sent to IVF program in a very liberal basis without any exploration being done for the moment. And if you look in the literature, and when you mention the term unexplained infertility, we can ask us the question if this infertility is really unexplained, because when you are doing no exploration, you cannot say that it's unexplained infertility. And as there's not laparoscopy to be done anymore, we have a lot of expertise in those who have to perform this laparoscopy. And so they are not used to do it anymore, and so they are skipping it in the exploration of the infertile patient. Now, if you look at the WHO, then it is mentioned that diagnostic laparoscopy is recommended as a minimal requirement in the investigation of female infertility. So what we are seeing now is that the standard diagnostic laparoscopy as a pure diagnostic tool is postponed in the exploration of the female pelvis, or even not done anymore, because it's rather invasive, it's not innocuous, you need to have some expertise, and it's faced with the results of RT, which at this very moment are going up in good hands, up to 50% of pregnancy rate. So, coming back to the hysterosalpingography, should we not explore the tube with hysterosalpingography? And yes, you can do it, but you must be aware of the false positive and negative of hysterosalpingography. And this is a publication of Ben Moll of the Netherlands, and he showed clearly when your hysterosalpingography showed two-sided abnormality, then the laparoscopy is normal in about 42% of the patients. And the same is with the publication of Danahatu, where bilateral obstruction and either salpings at hysterosalpingography, only 41 was confirmed at laparoscopy, which means if you omit laparoscopy in your exploration, then 60% of your patients will have an incorrect treatment. Now, what about the laparoscopic findings in infertile, so-called unexplained infertility with a normal hysterosalpingography? So not the pathological hysterosalpingography, but the normal one. And these are data which you can find in the literature. And then you see that if you perform a laparoscopy, you can find abnormality in around 50 to 80% of the patient. So what we were looking for was to find a minimal invasive exploration which is accurate, which can be done in an ambulatory setting, and where we can evaluate the implantation function and the transport and pickup function of the tube. Now, the idea came in 1998 because we are doing a lot of oocyte pickups, where we're going in with a simple needle to pick up the oocyte, simple needle going into the pelvis. So, if we can use this needle and dilate the diameter of the needle up to 4 millimeters, then we can remove the needle and put in an endoscope. So that was the idea which we started to do the transvaginal laparoscopy in 1997. And so by doing so, transvaginally, we can perform, and that's called by Antoine Waterloo, the fabuloscopy. It's a combination of hysteroscopy, the transvaginal laparoscopy, the salpingoscopy, and a patency test. So going in with a needle in the patch of Douglas, just about 1 centimeter under the posterior lip of the cervix on the midline. We are now using a spring-loaded needle where the length of the needle can be preset between 1.5 and 2.5 centimeter, depending upon the obesity of the patient. The spring-loaded needle has the advantage that it goes very quickly, so you have not to push inside the patch of Douglas, and so that you have less stenting of the peritoneum when you try to go into the pelvis. For the hysteroscopy and the transvaginal laparoscopy, we are using the same endoscope. It's 2.9 millimeter endoscope, and as a dilatation medium, distension medium, sorry, we are using a rotary distension medium. So no gas, always a rotary distension medium. And this is one of the videos. So you are seeing the posterior side of the uterus. This is the landmark. So your image is upside down, and so you can follow easily the tube and the ovaries. And important here is that before you start to do the exploration, you leave in about 150 cc of ringer lactate, pre-warmed one, and then you can easily explore the tubes and the ovaries. And in fact, you're coming with your endoscope in the longitudinal axis of the tubes and the ovaries. So you have not to manipulate. So it gives you the opportunity to explore tubes and ovaries in the normal physiological position without any form of manipulation. So you can do this under sedation. You can, if you are trained enough, you can do it also under local anesthesia, and the patient can look at the screen when you're performing the procedure. So it's minimally invasive, it has an easy access, no scar formation, and it has a high patient satisfaction. Important is that you select your patient. So the patients, these are patients where you perform a vaginal examination. Clinically it's normal, and where the ultrasound is normal. So if you see a big endometrium exist, then you know that you have to operate, that you know, and you have to do something. So you have not to perform this diagnostic procedure. So the contraindications are acute pathology like bleeding or infection, and obliterated patch of Douglas. Coming back to one of the questions, if we can look and perform a salpingoscopy, yes, we can do it with the same instrument and without the manipulation of the tube. You can have a look inside of the tube and see how the tubal mucosa is looking at. So the first two are completely normal salpingoscopies. The last one, you can see it's a little bit dilated, so the tubal wall is thinner here, and so, but the tubal mucosa looks healthy. So these are patent tubes. Also, these are patent tubes. But if you look at this mucosa, and that you will not detect with ultrasound, then you see that this mucosa is abnormal. And this patient had chlamydia negative, so even by performing your chlamydia testing, you will not be able to detect this. So it's an easy exploration to be performed in an ambulatory setting in those patients. The feasibility, well, if you go at the literature, the success of entry is around 95 to 97%, and I'm coming back on the complication rate later on, because one of the main criticism we had when we started up in 1997 was you will have a lot of rectum perforations when you're doing that, because you're going in through the patch of Douglas and the rectum is very, very close. So, and that was the reason why I didn't start up in the United States, because we presented the first time at one of the ASRM meetings in San Francisco many years ago. Now, what is accuracy? What is accuracy of the transvaginal approach? So we did in 10 patients. We performed at the same moment by two different surgeons, a standard laparoscopy and a transvaginal laparoscopy. And the surgeon who did the standard laparoscopy didn't tell his findings to the surgeon who performed the transvaginal lap. So it was written down by a third person. So, and we had to look at the presence of ovarian adhesions and in patients with mild endometriosis and in unexplained infertility. So, at standard laparoscopy, we found 40% of adhesions present in patients with mild endometriosis. Unexplained infertility, no adhesion, because otherwise it was not an unexplained infertility. And then we performed, at the same patient, at the same moment, the transvaginal laparoscopy. And then you see that in mild endometriosis we found 70% of adhesion formation. And then in so-called unexplained infertility, there was 45% of adhesion formation. So your accuracy is much better by using the transvaginal approach because you're using a watery distension meter, and the CO2 pneumoperitoneum has a high intra-abdominal pressure, which in fact is going to mask your small adhesion formation in those patients. So these are data from other people where you can see the concordance between the transvaginal laparoscopy and the standard laparoscopy, which is the same which I just told you. So we have the, we always do before we are starting the transvaginal laparoscopy, we have an ultrasound machine in the operating room, and each patient receives an ultrasound before we are going to start the procedure. And when the endometrioma is smaller than 15 millimeter, it's a simple 2D ultrasound, it's not a sophisticated technique. Then we miss that ultrasound about 45% of the small endometriotic lesions which are present. Oh, Microsoft PowerPoint, so probably. Sorry for that, I don't know why, but let's start again. Where was I? So these are the images which you can see inside of an ovarian endometrioma, which is small as 1 centimeter. So it's really a very active lesion which you see there with a lot of neoangiogenesis. So the failed axis is due to several reasons, which you can see here: peritoneal tenting, excessive adhesions, retroverted uterus, nodular rectal cervical endometriosis, and adnexal mass. But these the three last are in fact contraindication to perform the procedure. Now, if you come to the complication rate, we went through the literature to see the impact of rectum perforation when we are performing this. Now, to make a long story short, in total we had 13,360 procedures, and the incidence of rectum perforation is 0.37%, and the infection rate is very low. And important here is that these rectum perforations all have been treated by simple conservative treatment, which means that you do nothing and you just give patient for 5 days antibiotics, and they will have no problems afterwards, because the hole you made is very small and you see directly that you are in the rectum. So you have not to turn around with your endoscope, just pull back your endoscope and leave it like that and give patients some antibiotics. And these are other data from the group of the Netherlands, which shows just the same data as we had in our findings. And also here you can see that training in fact has an impact of your complication rate, and the more you are doing, the less complications you will have at the always is. So I think the transvaginal laparoscopies is in fact, we are using it as first line technique in the exploration of the infertile patient. It's very feasible and it's accurate, and it can be done in a one-day hospital setting. So then another point was, can we perform some operative procedures by using this transvaginal approach? Although initially it was developed for pure diagnostic reasons. Now, you have no panoramic view, so if you do some surgical procedures, this will be limited, minimal procedures. Now, we are using the same scissors as we are using for hysteroscopy, so these are 5-range scissors or forceps, and we are always using a bipolar coagulation needle or bipolar probe. So it's Hartmann solution or ring lactate, so you cannot use a unipolar system. So always use bipolar. Now, one of the most important interventions you can do transvaginally is the ovarian drilling. And you can do the ovarian drilling by using the bipolar needle. You can also use the Vesa point or a diode laser. And this is the bipolar needle, which you can see here. It's on the top, it's 0.2 millimeter the size. And this is an example of the drilling. So important is that you are always perpendicular to the ovarian surface, and you can easily perform this drilling. And it gives you also the opportunity in patients with PCOS to have an exploration of the pelvis, because then you know that the tubes are known, yes or no. This is the use of the diode laser, which is in fact the same principle, but mostly we are using the bipolar probe because it's less expensive than the use of a diode laser. But if you are very rich, you can have this diode laser to perform the ovarian drilling. And this is the final result. So mostly we are performing about 10 holes in each ovary. That's what we are doing. You can discuss that. We have really no data to tell you if 5 is enough, or maybe is 1 only enough. So, but mostly we are performing 10 holes. So, and these are our results. So, in fact, by doing so, we are coming to about 57% of in vivo conception rate with or without intrauterine insemination, and all the rest of the patients which were not pregnant or sending them to an IVF. But that means by performing an easy procedure, you can reach a pregnancy rate of around 60%. This is also confirmed by data of Professor Ma from the Beijing University in China, and also she has a very good spontaneous conception rate, which is around 50%. These are data from Professor Otterlo, where he had a look at the pregnancy rate related to the duration of infertility. And you see that the longer the infertility stays, the lower the pregnancy rate is. But in the mean, he also reached pregnancy rate between 50 to 60%. And these are data which you can find in the literature, also showing that the results with the transvaginal drilling are just the same as after laparoscopic drilling. Now, one of the concerns of the ovarian drilling is that you will have the formation of adhesions after the procedure going up till 80 or 70% in those patients. Now, there's a huge difference if you perform a drilling like this or if you perform a drilling like this. So, if you do it the first picture, then your risk is very high that this patient will have a premature ovarian failure. We were lucky that in some of the patients we were able to perform a second look, because patients get pregnant and then afterwards they get oligomenorrhea again, and he came back asking to repeat the procedure. And this is what we found. So the drilling gives in fact some small blood vessels upon the ovarian surface, but there were really no adhesion formation, stricto sensu present. Now, in December 2016 and January 2017, there was a very nice publication from Gianpaolino from Naples, where he performed a laparoscopy and transvaginal laparoscopy drilling in a prospective way in those patients. He had to look at the AMH pre and postoperatively, and also the pain postoperatively. And you see that the pain score is much higher when you're doing by laparoscopy compared to the transvaginal approach. But what he did, and that is very important, is that he had to look in the same group of patients 8 weeks or 12 weeks later. He performed under local anesthesia a transvaginal laparoscopy to have a look at the formation of adhesion formations. What you can see here, that when you're doing the drilling laparoscopically, he found in 70% of the patient adhesion formation, while when performed transvaginally, there was only 50% of this information in those patients. So I think that with the available and new data, that there is no doubt that the transvaginal endoscopic approach is a method of choice for performing ovarian drilling. The second point is the minimal endometriosis, and I will just show you how it works. So this is a small endometriotic cyst. We did some additional analysis, and with the bipolar needle, we are going to open this cyst. This is a cyst of 1 centimeter. So if you look inside the cyst, you can see this active endometrial-like tissue which is present. So it's not because it's a small cyst that it's not active endometriotic lesion which you can find inside. So we are using the bipolar probe just to coagulate this, and this is what you can find afterward. So you have no carbonization. You can clearly see the invagination of the ovarian cortex, and the color effect of the basis of the ovarian cyst is the same as the cortex of the ovary, clearly demonstrating the invagination theory of Houston and Sampson. This is another example, again, a small cyst, which you can see there. And we used the same bipolar probe for performing the coagulation. But again, you see the presence of neoangiogenesis in this cyst and the presence of endometrial-like tissue. So even this small endometriotic cyst is very, I guess. Now, as already mentioned by Professor Grudzinskas, the tube is one of the causal factors in ovarian cancer. There are a lot of data now in the literature which are available. And so what we are doing now, we developed a system where we can make a cytobrush of the fimbriae. And it's available, it's not mine, I did not find it out, it's a cytobrush which is available at Cook Medical. You can buy it like this. And it's a cytobrush. You go in with the cytobrush within the fimbrial end or within the ampulla, and so you can turn it around. And so by doing so, you can collect the cells of the tube, and on these cells you have enough material to perform not only histology, but you can do immunohistochemistry, you can detect P53 or K67, whatever you like to do. And very recently, we found out that in patients with HPV, so women and men, so if you look at the pregnancy rate after intrauterine insemination, so if both were negative, the pregnancy rate was 12.2%. If the man was positive, the woman was negative, pregnancy rate is going down, and the same vice versa when the woman was positive, it's going down to 7.3. And when both are positive, we had no pregnancies in those group of patients. So what we are going to do now is to use a cytobrush to see if we can find some HPV in the fibrillar end of those patients. And we just published this very recently. So let me come to the conclusion. I think that transvaginal laparoscopy in absence of a panoramic view allows for minimal invasive procedure. Always use ringelactate as distension medium, and therefore you have to use a bipolar cure. And it allows for an early detection of the endometriosis in a minimally invasive way, and it is the method of choice in cases of rare clomiphene-resistant PCO. We will have another meeting of tubal management in Bucharest in September. So thank you very much for your attention.
І прошу питання. У вас було питання, будь ласка.
Thank you very much, Stefan, for fascinating. Here, on your left side. Thank you very much for this fascinating and advanced sort of a practice. I just wanted to ask you a couple of questions. One is, in your fertility treatment pathway, do you routinely advise the vaginal laparoscopy? And the second one is, how do you rule out the obliteration of pouch of Douglas? Is that by scan? Just scan?
We are rolling out the obliteration of pouch of Douglas by vaginal clinical examination. It gives you already a lot of information. The problem is that a lot of people are not doing this anymore at this time. And also, yeah, but no, that's true. The young people are not doing this anymore. and also a vaginal ultrasound. So both have to be normal. Yeah? You cannot exclude for 100% that you will have some disinformation in puncture douglas, and that's one of the reasons why sometimes you will have failures. And what's your first question?
In your fertility treatment pathway.
Yeah. So depending, if there is a severe male infertility problem, then patients are sending, we are doing an hysteroscopy, an ultrasound, and then patients are sending to an IVF program. But in all the other patients, where we find on ultrasound no pathology, so let us say the so-called without obvious pelvic but pathology, so negative ultrasound, negative vaginal examination, infertility duration of 2 or 3 years, normal male, then we are doing transvaginal laparoscopy. So we are not performing hysteroscopinography anymore. But maybe we can change and we can do each code. Thank you very much. No, but I think it's important. We should re-evaluate this. Yes.
Питання є у доктора Дощечкіна, будь ласка.
Thank you for your presentation. Concerning unexplained infertility question, what do you think about tubal scoring as a carrying score and other during laparoscopy? Is it useful?
It certainly is useful. As you have seen, I showed you some slides, but some pictures, and certainly in patients with outer salpinges, it's very important, because the idea for the moment is that if patient has outer salpinges, you have to move the tubes and you have to send patients to IVF. I do not agree with that. You have to open the tube and you must have a look inside of the tube. And if your tubal mucosa is rather healthy, if you have no intratubular adhesion formation, we showed in the past that these patients, when you open the tube and you perform a salpingostomy, that those patients have a pregnancy rate which is around 50% with low ectopic pregnancy rate. If the tubal mucosa is too much damaged, okay, then I agree you have to move the tube and you have to go for IVF. But the tubal mucosa indeed is very important.
Дякую, Стефане. Ще є у доктора питання, будь ласка.
Перш за все хочу подякувати за цікавий доклад. Таке питання. Мене дуже порадували дані по HPV чоловіка і дружину про результативність. Чи входить в обов'язкове обстеження чоловіка вірусне, коли пара обстежується? На HPV.
Well, these are very new data, so just came out. So I cannot tell you more than what we have. So we found it out, and we are now doing it in a systematic way. So maybe in 2 years I will tell you more.
Я дякую, ми просто займаємося такими проблемами, такі у нас є деякі зміни опубліковані дані, тому я цікавлюсь. Дякую.
Дякую вам, Стефане. Ще питання.
Thank you very much, Professor, for the
Володимир
beautiful
Володимирович,
presentation.
будь
And my
ласка.
question is about you tell more about the many advantages of hydrolaparoscopy, transvaginal hydrolaparoscopy. But my question is from a practice side of doctors. In your opinion, why this type of investigation is not so practice useful? Not very newest investigation. About 15 years as they did mistakes, as the files that did mistakes. But in your opinion, why? For example, in Ukraine, in all clinics in our country, we have a high level of laparoscopic equipment, but not more than 3 clinics has this type of equipment. Your opinion, please.
Well, that's a good question. I've also asked this question to myself, why it takes so long from 98 up till now before people are going to do it. And that's because you need another setting. So it's another approach, it's completely different. So it's initially it's pure diagnostic. First of all, diagnostic laparoscopy is not done anymore in most of the patients. And if you perform laparoscopy, you're going to do an operative laparoscopy because you're going to treat hydrosalpinges or you're going to treat endometriosis, etc., etc. This is not the intention of this procedure. The intention is to have a diagnostic one and to have an accurate treatment of your patient with an accurate diagnosis. And the reason that it's not commonly done is that doctors are afraid for doing it, and that it needs another setting, it needs another approach, and it's not taught at the university hospitals, and that's one of the main reasons. So now they are starting in Belgium at the University Hospital of Michel Desolles, where they are going to teach people to do the transvaginal. And so what we are seeing the last 5 years is that's coming up on.
Дякую. Стефане, прошу ще питання. Ще є питання, колеги? Немає. Thank you very much. А зараз у нас є можливість послухати доповідь, яка стосується традиційної лапароскопії і значення оцінки стану органів малого тазу для лікування неплідності. Я з задоволенням запрошую до слова Антуана Ватрело, також з Великої Британії, який є фахівцем в сфері репродуктивної хірургії. Прошу, доктор Антуан.
Thank you very much. First of all, I'd like to thank you, André, for his kind invitation, as well as the organizing committee. For me also, it is my first time in Kiev. I very much appreciate, and I hope that it will be the first trip of many trips and collaboration in the future. So, everything has been said, most of them by Stefan concerning the tube. And I want to show you, I will say, a panorama of what we can think today about this approach of the tube. First of all, we have to see from anatomy to endoscopy, because we will see that the tube is a complex organ, and today nobody is really able to answer to this question. What is the normal anatomy of the tube? We have important variations in length, 6 to 20 centimeters, in morphology, in vascularization, and we know that we have probably variation in the normal anatomy in more than 35% of cases, and there is very few work about that. What we know for sure is that the ampulla and fibria are the most important part of the tube, and we have to focus, I think, our attention on this part. So the classical anatomy, they said that the average length is 11 centimeters. There is 4 portions, as you know, interstitial, isthmus, ampulla, and the femorial. We have then the topographic anatomy, and we can define some space, like the cross fossa between the tube and the ureter, and inside there is a Claudius fossa, and could be good things to know when you do laparoscopy of the tube. And then we have to be quick the vascularization, and we have to know that this vascularization is common with the ovary, and we have some surgical implications when we are dealing with the tubes. If you impair the vascularization of the tube, you may impair as well the vascularization of the ovary, so you have to pay attention. And then, I will be quick about that, there is a lot of subtle abnormalities which are quite new, but we have very few works about that. And you have this morphologic tubal variation. They are often, in fact, Mullerian remnant, so they are considered as normal. And for instance, the paratubal cysts that we call the hydatid of Morgany as normal are normal when they are very small, but sometimes they are big, and we'll show you some examples. And then we can question the impact on fertility. Then we have the accessory tube. We have the circulation of the tube, which is a lack of muscularis of layer of the tube, and that also is something that we have to take in account. So, what are the endoscopies to test and to check the tube? So we have some. We have, of course, laparoscopy. We'll show you some example. We have what was described by Stefan, the transvaginal laparoscopy. We make slight modification. We call that fertiloscopy, but basically it is a TVE, transvaginal laparoscopy. Then hysteroscopy may be of some use. And of course, we may combine that with the salpingoscopy, and we will see, and it has already been mentioned, the interest of the evaluation of the tubal mucosa. So, Tube is a complex organ. That is why endoscopy is very important, because only endoscopy allows to evaluate the tubal mucosa, the tubal muscularis, and also the non-obstructive lesions. Kamal Hoxha demonstrated very clearly that we are very able to establish the patency of the tube when you do ultrasound, but for non-obstructive lesions it is more difficult. Maybe in the future, if we make some progress in ultrasound, it will be able to do that. Today, it is questionable. And of course, if you detect, we have also to treat at the same time if possible. So first of all, the laparoscopy. You see here a small example of Idatid of Morgani. So I'll show you some video. Okay, so just to show you some structural variation of abnormalities when you do laparoscopy. So first of all, we have to say that if you want to see the tube during laparoscopy, you have to move the tube. It is a big difference when you do transvaginal laparoscopy. And you have to use smooth instrumentation without teeth. You see this patient have, in fact, endometriosis, it was for the purposes. And that we did the laparoscopy. You have seen that there was a small paratubal cyst, and you can see here, I don't know if we have you can see here the small paratubal cyst, that it is Idatid of Morgani. When it is this size, it is considered as normal. And then you see this tube, apparently the patency is good, we have a small paratubal cyst, and if you look here, you have quite a big cyst, and it is, you know, usually people say we have nothing to do about that. In fact, there is now some evidence that we have to remove this small cyst because it may, you see the patency is good, because it may impair the ovum pickup. So when you have this kind of, I will say, quite big cyst, around 1 centimeter or more, probably it's worth to remove the cyst. We have to do it in a gentle way. You see it is in fact quite an easy procedure to do, and it will increase probably the capacity of the fibria to make ovum pickup. So you see it is simple things to do. And you see that the cyst is almost as big as the fibria. And it's just a question of remove the tube. If you have to do cauterization, you have to do limited cauterization. And at the end, you can remove it. Also, we have what we call the bridge adhesions, so this tube is patent. You see this kind of adhesions. If you don't explore manually the tube, you cannot see it. And look, you have like a kind, you know, of small dilatation of the tube beside here. And look, it is very simple, just to make a small coagulation because there is the vascularization is big at that time. Just very simple, you can cut it, and look, immediately you open the fibria end. And so that probably gives you good result when you do it. Then we have the stereoscopy. Stereoscopy of few use, except if you want to test the proximal end of the tube, and you can do some kind of cannulation of the tube, or I will say selective salpingography if you think that you have proximal obturation of the tube. We don't do anymore the falloposcopy because falloposcopy don't give you any good imaging, so it has been totally abandoned. Then we have the transvaginal. I will be quick because already Stefan explained you everything, just to show you what we do in a small cartoon, which is more or less, it is basically exactly the same technique, totally derivative from what Stefan showed you. Just we do that with disposable instrumentation, so we use a Veress needle to start, then we fill the pouch of Douglas with some saline, around 150 cc, and then we have a special introducer, so it is only puncture in the pouch of Douglas. And when we are in, we have a small balloon that we are inflated. So it means that when we are in, we have no risk to be pulled out of the pouch of the glass. And then we insert, in fact, a standard hysteroscope, 2.7 millimeters. And we may start the examination. And what the interest, you see, but already you have seen the imaging. We are very close to the genitalia. So it is quite easy to have a good exploration. And even you see that we are close to the fibria end. And it is rather simple to go in the tube to do the salpingoscopy at the same time. So just to show you how it works, you see that the fimbria end. You already have seen this imaging from Stefan. What it is important is to have a close inspection of the tube to see if everything is normal. You see these small floating adhesions. And then we do the dye test, and we can also go inside the tube after that. I think we'll see the dye test in this patient, in this video, I think, yes. And so we do the dye test through the vaginal route, and you see when we have this kind of dye, we think that everything is perfect. Also, to show you the tubal circulation in the subtle abnormalities, you see this dilatation of the tube. We are doing a fertiloscopy, and you see there is a totally lack of muscularis layer of the tube. And you will see that if you go inside the tube, which we are going to do now, you see the fimbria. So we are going to go inside. And you will see that by transparency, you can see the bowel, which means that really the tube is very, very, very thin. You see here the folds, and by transparency, you can see the fatty tissue, which means that this tube has a totally lack of muscularis layer, which is a problem, and I think nobody knows exactly how to treat it today, but it is probably a problem that we have to solve in the future. So we arrive to the fourth step, which is salpingoscopy. I think it is important to do it because, as you know, the most important part of the tube is the tubal mucosa, and if the tubal mucosa is not good, we cannot do anything. We can do the salpingoscopy during the laparoscopy. It was described first by laparotomy, then by laparoscopy. But you see that it is quite difficult because you need to have two scopes, two irrigation systems. So very few teams, in fact, are doing salpingoscopy on a routine basis. If you do that transvaginally, it is another story because in a couple of minutes you can go in the tube, like in this example. So you see without any manipulation, you go in this tube. And you see this tube is quite normal. The tubal mucosa is quite good, but the folds are a little flattened. So it is not perfect, but at least there is no adhesions. When we have to detect, the main factors in the tube is the adhesion, the crisscross adhesions intraoculary. If you have any adhesions in the tube, it is a tube that we have to remove because the function will be obviously bad. The only things you can get, it is an ectopic pregnancy. So it is why this exploration is important. We tried to go a little further in the past, and we did what we call to try to do the microanatomy of the tubes, because the more the nuclei are distend when you do the dye test, the more damaged the mucosa is. It was the work of Marconi in 1999. And you will see that we can see that very clearly on the tube. So now we are in the tube, we do a salpingoscopy, and we have a small magnification wheel on the hysteroscope. It is the hysteroscope from AMU, and we may have a magnification up to 100, and we will see when you activate it, like here, you see every blue spot here, in fact, are nuclear distend by the blue. And the more we have it, you see we have at the level of the cells, because you can see the small vascularization and the red cells in the tube. And when we have a lot of distend cells like that, Marconi demonstrated that the pregnancy rate was much less important than when you have normal tube. You have seen that it is ismolari or polarismic junction. We cannot go further, of course, because it is too narrow. And then it is why it is probably interesting to do this exploration. So far, there is very few works about that, so we cannot be sure, but at least you see that when we see this kind of aspect, we have to pay attention of this tube. Now I give you another example of a totally different tube. You see that it is, we are now in the tube, and you will see when we do the magnification, like here, you just see the microvascularization of the tube, You see the red cells in the tube, and we have no blue spot. And we have made a lot of microbiopsy when we have this kind of blue spot, and we know that it is either inflammatory cells or cell in apoptosis. I will show you a last example of abnormalities. So that it is for us a totally normal tube. And now you look that it is totally different. What you see this tiger aspect. Everything is blue. And these cells are either inflammatory or in apoptosis. So we try to treat this patient with antibiotics for 2 months, and in 30% of cases we decrease and we repeat the fertiloscopy after that, and we have an improving and a decreasing of these cells. It means that all the inflammatory cells disappear. Of course, when we have apoptosis, these cells stay. We have to say that it is absolutely experimental, we cannot rely on that, but I think it is important to know that today we do a lot of things concerning IVF, and we have still a lot of things to do concerning the tube, which is still not very well known, in fact. So now, what is the strategy for tubal endoscopy? I think that, as Stefan said, the transvaginal approach should be preferred if there is no obvious pathology. It is the best way to do salpingoscopy. You have seen it is quite easy to do, which is not the case in laparoscopy. But obviously, laparoscopy remains the gold standard when pathology is suspected. And so in conclusion, I will say that tube are complex organ and maybe correctly evaluated only via a thorough endoscopy. I think that it is, the best take-home message. Tubal patency is only one, of course, important of the parameters that should be addressed. And anatomical variations are important, and then their impact on fertility is still not very well known. And we are starting quite a big study, observational study in the world, which is called the SUTUBA study, to try to see how many subtle abnormalities are present. It is the first number one, and then the second one, which will be more difficult, will be to try to see the impact of these abnormalities on fertility. Thank you very much.
Будь ласка, питання, доктора. Немає питань, так? Thank you very much. No question. Ми вичерпали програму нашої першої секції, тому запрошуємо всіх на каву і на додаткове спілкування. Прошу.
Почекайте, за що я гроші заплатив? Пацієнтка прокидається, подивилась на живіт.